Welcome. My name is Kathy Blay. We'll be talking about transfusion therapy. Topics will include antigens, antibodies, pre-transfusion testing, blood components and indications, blood administration, informed consent, documentation, and finally adverse reactions. Antigens are found on red blood cells, as you may remember. Antibodies are found in the plasma. Some antibodies are naturally occurring, while some are only formed after the body recognizes an antigen as foreign. In the picture below, you can see the antigens are on the red blood cells. They are the blue dots. Antibodies are the Y-type structures in the middle. And you can see on the right-hand side what happens when you combine an antigen with its corresponding antibody. Agglutination is allowed to form. When transfusing patients, what we don't want to do is combine an antigen with its corresponding antibody. Doing so will result in premature destruction of the red blood cells. The ABO system is the most important blood group system that we need to discuss. You may remember, if someone is a group A, they have A antigens on their red blood cells and anti-B in their plasma. Someone who is a group B has the B antigens on the red cells and anti-A in the plasma. If someone is AB, they have both A and B antigens on the red blood cells and neither antibody in their plasma. Someone who is a group O has neither antigens on their red blood cells, but they have both anti-A and anti-B in their plasma. These antibodies are naturally occurring and they form after about 6 months of age. About 45% of the population is group O, 40% group A, 11% group B, and 4% AB. The next most important blood group system we need to discuss is RH. A third antigen determines the RH factor. It is called D. A person with the D antigen is RH positive, and you can see that on the A positive red cell there is the yellow D antigen. A person without the D antigen is RH negative, as shown on the right, without the yellow antigen. 85% of the population is RH positive, while 15% RH negative. Anti-D is only formed after exposure to the antigen, and that would be either through transfusion or pregnancy. Anti-D does not form naturally like the ABO antibodies do. I've given you a compatibility chart for red cells. You can see that a patient who is a group A can receive donor units that are A or O. An O person can only receive group O red cells, while an AB patient can receive red blood cells of any donor type because they already have the A and the B antigens. Also note that group O red cells can go to patients of any type. When you consider compatibility for plasma, it may seem a little bit backwards. First, you can see a patient who is an A can receive plasma from an A donor or an AB donor. In fact, any patient can receive AB plasma. This is because there are no ABO antibodies in AB plasma. Note that an O patient can receive plasma of every type, and that is because there are no ABO antigens on the O red cells of the patient. AB patients can only receive AB plasma. There are many other antigens on red blood cells besides the ABO and RH that we've already talked about. Examples are from the systems of Cal, Duffy, or KID. Exposure to these antigens through transfusion or pregnancy causes patients to make antibodies. We detect these antibodies when we do the antibody screen which is part of the type and screen order. When we find that the patient has one of these other antibodies, we need to provide blood lacking the corresponding antigen. The specificity of the antibody will determine the percent of compatible red cells we will find and the amount of time we need to find them. Specimens are good for 72 hours. The day of the draw is always day 0. Samples can be used until midnight on the 3rd day. Specimens can be extended to 10 days or 1 month when there is a documented history of no pregnancies or transfusions in the prior 3 months. This is used in the pre-admission setting. Unfortunately, there is no good way for us to show you in the computer how long a specimen is good for. If you have a question, please call the blood bank. We use special red blood bank wristbands for all patients having a blood bank sample collected, and that includes blood bank hold specimens. The wristband has letters and numbers that are unique. The blood bank wristband is good for the entire patient's stay, as long as it remains attached to the patient's limb, that can be an ankle or a wrist, and as long as it remains legible. If you find that the blood bank wristband is getting too tight or needs to be moved for some reason, please call the blood bank for instruction, or we can send a phlebotomist to move the band. The ABO and RH is tested by 2 different techs when we receive a new patient. Then we do the antibody screen and then the cross match for red cells. The antibody screen is performed using a very sensitive method. We are looking for clinically significant antibodies. If we find a positive antibody screen, we're going to call you and let you know that we need extra time to complete this workup. You may ask how much extra time, but it's very difficult to predict at the beginning stages of the workup. We need to identify the antibody or antibodies. Patients can have multiple antibodies, further complicating the workup. Then we need to find units negative for the corresponding antigen, and then we need to cross-match them against the patient's plasma before we release them for transfusion. If a patient has multiple antibodies, we may have to order their blood from one of our blood suppliers, which could take 12 to 24 hours. Antibody identification testing and antigen screening is performed here at CMMC for Rumford and Bridgeton hospitals. Let's move on to uncross-matched blood. You're probably familiar with giving O-negative red cells to patients when we don't know their blood type. Once we know their blood type, and it's been tested by 2 different techs from a properly labeled sample, we may give you type specific. Type specific is still uncross-matched because the antibody screen has not yet been completed. If your patient is a male or a female age 50 and over, we may give you O-positive red cells. This is because only 8% of donors are O-negative. We need to save our O-negative red cells for O-negative patients and for females of childbearing potential. We try to avoid switching females of childbearing potential because if they form the anti-D antibody, it may affect future pregnancies. If a male or a female older than 50 forms an anti-D, it does not affect them. We just have to be sure to provide Rh negative blood in the future. We will ask you for the ordering provider. After the emergency is over, we will send them a signature request for the uncross-matched products because they are taking the responsibility for the uncross-matched products. If your patient is Rh negative but using a lot of product, we will probably have to switch them to Rh positive. Again, as above, if they make the antibody, it will be weeks or months down the road, and then we will have to be sure to give them only Rh negative products in the future, but it will get them through the emergency. We have a massive transfusion protocol. It should be activated when a patient has used or is expected to use more than 8 units of red cells within a 12-hour period. Notify the blood bank by phone. Please make sure you're speaking with a blood bank tech. We will prepare a large number of units, red cells and FFP, in a 1-to-1 ratio. We will pack them in coolers, which allows you 8 hours storage at the bedside. We will order labs and blood gases approximately hourly to help guide product usage. Off hours, it may be difficult for us to deliver coolers. We go down to 2 techs in the lab, and it takes 2 techs to sign out blood products. We may ask you if you have someone available to come get coolers. If you don't, we may need to involve the nursing supervisor and ask her to find someone who can run coolers. It's important to remember, each time you send someone to the blood bank for blood products, they must present with the patient's name, first and last name, and complete blood bank identification in order to obtain products. Let's move on to red blood cells. They are indicated for restoration of oxygen carrying capacity by increasing the circulating mass in patients with symptomatic anemia. Transfusion triggers are becoming more and more conservative. Our trigger now for an H&H is 7 hemoglobin and 21 hematocrit. Volume default is 300 ml per bag. Platelets are used for thrombocytopenic bleeding or functionally abnormal platelets. Functionally abnormal platelets may be caused from meds like Plavix or aspirin. Platelets are given prophylactically to patients with platelet counts less than 10,000. Normal range is 140 to 425,000 per microliter. Platelets are given regardless of ABO. They are stored at room temperature with constant agitation. Please never, never, never put them into a cooler. The infusion rate is determined by the volume tolerance. 1 pheresis is equivalent to about 6 to 8 units of platelet concentrates, but they're collected from 1 donor. The approximate volume is 2 to 400 ml, but the actual volume will be listed on the bag. These may also be called single donor platelets, and if you hear the term 6-pack, that's old terminology. What you'll want to order nowadays is 1 pheresis. We can irradiate red cells or platelets. The product is exposed to 2,500 rads of radiation, and this prevents the donor lymphocytes from replicating and making antibodies against the patient. This is indicated for patients susceptible to transfusion-associated graft versus host disease, which is almost always fatal. If we ever have directed donor units, those would be directed from a family member of the patient. Bone marrow transplant candidates and recipients, those are the ones needing irradiated products. Radiation-sensitive labels on the unit will indicate whether or not the product received enough radiation. By the time you get the blood product, it should be black, like on the bottom. Plasma must be ABO compatible. The RH does not matter. Plasma is stored at minus 30 degrees Celsius for up to 1 year. It is thawed at 37 degrees when needed. You'll want to give us about 30 minutes. Plasma contains proteins including all the coagulation factors. The approximate volume would be 250 to 300 ml, but again, the volume will be listed on the bag for you. Plasma is used for deficiencies of multiple coagulation factors in the presence of clinical bleeding or for emergent reversal of Coumadin. It should not be used as a volume expander or when coagulopathy can be corrected with specific therapy such as vitamin K or factor concentrates. Cryoprecipitate is another blood product offered by the blood bank. It's not used frequently. Usually it's used during massive transfusions or with patients with low or dysfunctional fibrinogen. It's about 100 mLs, but again, the volume will be listed on the bag for you. We all have our parts in providing safe transfusions. In the blood bank, we must identify the patient and the sample, perform testing properly, store and handle blood products appropriately, release the correct product, and document all of our activities. The transfusionist must prepare the patient, the site, and equipment, identify the product and the patient properly, administer the product, assess for reactions, and document all activities related to the transfusion. Before the transfusion, the nurse must consider the following. Have the physician's orders been checked? Has the patient consent been obtained? Have the patient's cultural or religious beliefs been considered? If you realize that a transfusion needs to be canceled, please call blood bank, as only the lab can cancel the transfusion orders because they are in process once they are placed. Please notify us as soon as possible so that we can cancel the order and avoid unnecessary transfusions. Prior to transfusion, you'll verify the physician's orders as to the type and number of components to be transfused. Take and document baseline vital signs. Verify the consent is in the chart. This is required for all non-emergent transfusions. You'll make sure you have an IV with isotonic saline with a 20 gauge needle or larger. Isotonic saline is the only fluid permitted by the FDA to be administered with blood products. No other fluid, drug, or additive may be administered in the same line. Solutions such as lactated ringers have been attempted, but they contain calcium, which will cause the unit to clot. Once you're ready for us to send blood up to you in the pneumatic tube system, you'll want to call blood bank, specify the component that you want, the patient's first and last name, the complete patient's blood bank identification, letters and numbers, and your location. We will do our double checks and issue it in the computer and tube it up to you. You will use the last 4 digits of the blood bank identification that you gave us over the phone as the code to get the pneumatic tube to drop the blood so you can retrieve it. Please remove the blood product, initial the received by and write in the time that you took the product out, and return the form, the bag, and the red carrier to us at Station 9. That just tells us that you have the product. It does not mean you've done any of the checks yet. We only issue products for 1 patient at a time. Components should not be requested until they're ready to be transfused. We normally issue only 1 unit at a time. Identification is the most critical step in the transfusion process. It is tragic that patients continue to die every year because physicians, technologists, nurses fail to read names and numbers. 2 members of the patient care team, one must be the transfusionist, must verify that the patient and donor information are correct. Items that need to be checked are in bold font on the transfusion tags that are sent. Any discrepancies must be resolved prior to administration. Component. The component unit number, ABORH, and expiration date on the tags must agree with the information on the component's label. There are 2 tags sent with every unit. 1 copy must remain attached to the unit during the entire transfusion. The transfusion record must indicate that the unit is compatible when you have red cells for transfusion. Please be sure to note patient's name and unique identification number on the transfusion record must be verified against the patient's red wristband. the ABO and RH must be verified against the type and screen results on the chart. 2 RNs must sign the paper form or witness in power chart. It is not necessary to do both. All activities related to the transfusion should be documented: the site, peripheral or central line, gauge and needle type used, start time, rate, observations, mLs of saline and blood products, treatment, complications, and completion time. Transfusion should begin within 15 minutes of release from blood bank. If this is not possible, the component should be returned to blood bank immediately, or it may have to be wasted. Starting a transfusion is a critical step because the transfusionist has the last opportunity to prevent a misidentification and the first opportunity to detect a transfusion reaction. All components must be filtered. Components should be spiked with the bag in a hanging position so as not to pierce the side of the bag. Transfusionist must remain with the patient for the first 5 minutes of the transfusion at a minimum. Vital signs must be taken and documented at the following intervals: 5 minutes from the start, 15 minutes from the start, not since the last set of vitals, 30 minutes from the start, and every 30 minutes thereafter if the patient is stable. 30-minute post-transfusion vital signs are very important. You can still detect signs of a transfusion reaction. The unit must be completed prior to expiration or within 4 hours from the time it was released from the blood bank, whichever is sooner. Any observations about the transfusion, rate of infusion, treatment, complications, or reactions occurring prior, during, or post-transfusion should be documented. Unless otherwise indicated by the patient's clinical condition, the infusion rate should be no greater than 5 mL per minute for the first 15 minutes of the transfusion. Blood warmers are used in massive transfusion situations or when patients exhibit cold agglutinin activity. Blood is passed through a warming coil immersed in a 37-degree water bath. The temperature of the water bath must be taken at the start and finish of the transfusion and recorded on the transfusion record. The temperature should be 37 degrees plus or minus 1. Elevated temperatures will cause the RBCs to hemolyze. Adverse effects can result from a transfusion. Transfusion reactions will be classified as hemolytic or non-hemolytic. You can have transmission of an infectious disease, transfusion-associated graft versus host disease, trolley, and TACO. Hemolytic transfusion reaction occurs when a donor red cell and recipient plasma are incompatible. Undetected serological incompatibilities can cause these reactions, but most immediate reactions occur when clerical or other ID errors lead to an ABO mismatch. You can also see a hemolytic transfusion reaction with a bacterial contaminated unit. Human error can be minimized by careful adherence to every detail by every member of the transfusion service and clinical team, from the phlebotomist to the medical technologist to the transfusionist. The most common initial sign is fever, frequently accompanied by symptomatic chills. You may see signs of a reaction after as little as 10 to 15 mL of incompatible blood has been transfused. These are the reactions that may result in death. Other signs and symptoms that may accompany a hemolytic transfusion reaction are chest pain, hypotension, nausea, flushing, dyspnea, back pain, pain or redness at the infusion site, hemoglobinuria, shock, generalized bleeding, and oliguria or anuria. Vigorous treatment of hypotension and promotion of adequate renal blood flow are the cornerstones of therapy for hemolytic transfusion reactions. If shock can be prevented or adequately treated, renal failure can usually be avoided. Delayed hemolytic transfusion reactions. These are due to amnestic responses in a patient who has previously been sensitized and in whom now the antibody is now not detectable. This usually occurs 3 to 7 days following the transfusion, where enough antibody can be produced to cause clinical signs and symptoms of extravascular hemolysis. Common symptoms include fever, anemia, and mild jaundice. Non-hemolytic transfusion reactions. Hemolysis does not occur. Common types are febrile, allergic, anaphylactic, and non-cardiogenic pulmonary edema. We need you to report the reaction, fill out the paperwork, and a pathologist will categorize the reaction later. Febrile reactions are found in 1% of all transfusions. It's defined as a 1-degree rise in temperature with no other medical explanation. Prevention includes premedication with acetaminophen and the use of leukoreduced blood products. Allergic reactions can occur due to foreign proteins in donor plasma. Common signs are local redness, itching, and hives. Treatment would be premedication with an antihistamine for future transfusions. A severe reaction can be in an IgA deficient patient. They may have severe anaphylactic reactions. They will need wash components in the future. It's important if you hear the patient say they have something unusual about their blood or they had trouble getting blood before, we always want to know more about that. So please get information from the patient and let us know. If you suspect a transfusion reaction, you'll want to initiate the protocol as soon as possible. First and foremost, stop the transfusion immediately. Notify the attending physician. Perform a clerical check. Notify the blood bank. We will order some stat labs to be drawn. Get post-transfusion vital signs. We'll send you up the form. You'll want to complete the entire front page of the protocol form. Review the sepsis criteria before the patient gets drawn, because if the patient meets the sepsis criteria in the middle of the page, you'll want to order blood cultures in addition to the labs that we are ordering. We don't have that information yet, so we don't know if the patient meets that blood culture criteria. So, best to get the patient drawn all at once. We will need you to return the unit, including any tubing, and hand carry it down or have someone carry it down in a red bag. You don't want to send something that's been opened through the pneumatic tube station. Finally, we will need you to collect and send down a urine sample so we can check it for blood and red cells under the scope. Trolley, transfusion-related acute lung injury. These are important reactions. They're probably under-identified, but people are still dying from trolley reactions. We must report these back to the blood supplier. There is no single test for trolley. You'll just start with the transfusion reaction protocol form, but let us know if the physician suspects trolley. Symptoms must occur within 6 hours of the transfusion, although most occur within 2 hours. The patient will have dyspnea, respiratory distress, fever, hypoxia, can also have tachycardia, hypotension, and cyanosis. Non-cardiogenic pulmonary edema. A post-transfusion X-ray will show fluffy bilateral infiltrates that may be referred to as a whiteout. You will see normal pulmonary capillary wedge pressure. The reason we have to notify the blood supplier is that if there are any other co-components collected from that donor, they will need to be quarantined. TRALI is caused by HLA antibodies, so when a donor is identified as causing TRALI, they will defer that donor. TACO, transfusion-associated circulatory overload. We see this one more frequently. You'll see acute respiratory distress beginning shortly after administration and up to 2 hours, dyspnea, tachycardia, acute hypertension, and pulmonary edema. They may have a dry cough, chest tightness, jugular vein distension, pulmonary rales. What we can do for TACO is split units for future transfusions. We did an audit a couple years ago, and I've identified some of the most common errors that we found. Unit numbers should be recorded as what you found on the bag, the W number on the bag, not number 1 or number 2. Vital signs must be taken at appropriate times, including a temperature for all sets. Don't forget the 30-minute post-vital signs. Start and stop times are very important, especially when we're trying to figure out the timing of a transfusion reaction. And if you enter the volume transfused, it will populate the INO. Thank you for your attention. Please feel free to call Blood Bank if you have questions about the products. Please note, blood bankers are not the best resources for questions about IVs or tubing or transfusion-related questions. But definitely any questions about the product, if you have a concern about the type that we sent you, is it safe for the patient, please ask. We're glad that you're checking. Thank you.